subtitle. Now I'm going to do an introduction about Dr. Jesse Hostetter. Dr. Jesse Hostetter, he's a professor and head of the Department of Pathology in the University of Georgia College of Veterinary Medicine. He's also is the executive director of the Tifton and Atenas Veterinary Diagnostic Laboratories. In this position, he is responsible for all aspects of the service, teaching and research mission of the department for the State Veterinary Diagnostic Laboratories in Atenas and Tifton, Georgia. Prior to moving to the University of Georgia, he spent 18 years at Iowa State University as a faculty member in the Department of Veterinary Pathology in the College of Veterinary Medicine. In this university, Dr. Hostetter was active in other department missions, including diagnostic service, teaching, and research. He is currently a section editor for pathology for the Journal of Veterinary Diagnostic Investigation and has been a member of the nomination committee for ACVP and the Enteric Disease Committee for AAV-LD. Dr. Jesse Hostetter, thank you so much for being with here today. And now I leave the podium with you.
Thank you, Javier, for that introduction. And thank you, everyone, for being here. And good morning. Hello from the University of Georgia in the United States, where it's now 7 o'clock and the sun is just going down. Let's see if I can get my screen shared. All right, we're off. Today I'm going to talk a little bit about an approach to interpretation of GI biopsies. And I've given this lecture a few times, and I always start the same way, and that's by saying that I really don't intend to try and represent myself as an expert in this area. In fact, some of you may have more experience than I do reading these biopsies, and I just have done a bit of this. Since 2011, I have done some work for the Gastrointestinal Laboratory. That's at Texas A&M University, and I read GI biopsies along with several other pathologists remotely. And so they're located in Texas, and I read those from Georgia. And over the years, I have seen a few endoscopic and full thickness biopsies. I've learned a few tricks, and I've learned some strategies, and it's those kinds of things that I really want to share with you tonight, and just try to give a practical approach really to looking at biopsies of the intestinal tract. And really our goals for today, one, I've just said about trying to kind of provide you with some strategies for evaluating GI biopsies. And the audience that I'm really trying to target with this talk is pathologists that are in training, pathologists maybe that are just out of their training programs, and pathologists that are new or maybe just frustrated with reading GI biopsies. And so we'll look at this and think about some systematic approaches that you can apply to all of the biopsies. We're going to focus on inflammation, and I'm going to try and go for an hour and a half. And if we have some more time, I will then we'll talk a little bit about neoplasms. At the end of an hour and a half, then we can answer any questions that you might have. And if you have questions before then, just send them into the Q&A, and I'll try and answer them as we go along. I think everybody has their favorite and least favorite biopsies to look at. For me, it's my least favorite is clearly bone. I like GI biopsies, but I find when I work with residents, and I've worked with them over a number of years, that GI biopsies often are, at least at the beginning of the career, one of the least favorite. And I've asked myself when I was preparing this presentation, why is that the case? And I put a list together. These aren't all things that I've come up with. These are things that I've read about as well. But there are a number of factors that really make these difficult to read. And I think the first one is probably the worst. And that's that, we look at a number of tissues, we look at liver, and if we see inflammatory cells there, well, we think of inflammation. But in the intestinal tract, we have a normal population of resident immune or inflammatory cells like lymphocytes and plasma cells. And we see that, and we have to look past it and think, well, that's normal for this tissue. And so the challenge then is, when is it not normal? When is it inflammation? we're really also at the mercy of the person who's taking these biopsies. If it's a surgical biopsy and it's full thickness, usually those are pretty good. It's endoscopic biopsies are tricky. And I'm here to tell you, if I had to take an endoscopic biopsy, they would be horrible. This is a difficult procedure. There is a steep learning curve. And I will tell you that there are people out there who are artists at this technique and always generate beautiful endoscopic biopsies. But at the beginning of that curve, I think sometimes you get biopsies that are a little more variable and maybe not quite what you were hoping for. There's going to be a lack of uniformity. A resident or someone may bring me a biopsy to look at, and I'll say something, and then they'll take it down the hall, and someone else will look at it with a different set of eyes and say something completely different. Diagnosis of neoplasms, especially lymphoma, is difficult, and if we get a chance, I'll talk a little bit more about that tonight. And also, we're talking about an organ with a vast surface area, and biopsies may not be representative, and so you may not have a picture that's accurate for the underlying disease process, and that's frustrating for us as pathologists, but it's also frustrating for clinicians when the report we send out doesn't make sense compared to the clinical picture. So I really just want to start at the beginning with intestinal biopsies, and that's thinking about looking at the history and trying to decide what is the quality of the biopsies that we have. Like any biopsy, we look at the signalment and history. I think in GI biopsies, it's, the parameters that I've listed here are very helpful, certainly diarrhea and vomiting. But one thing I also cue in on, and I look at these to try and raise my index of suspicion that there is going to be GI disease in this particular patient. And weight loss is something I cue in on, especially in cats. It can be really helpful to raise my index of suspicion. A couple of other things. One is hyperproteinemia, lots of causes for that, but GI disease and PLE, protein-losing enteropathy, can be one of those things. And I really like it if we get ultrasound results. I've got an image on this side of the screen that shows a thickened intestinal wall on ultrasound. That has been shown to correlate pretty nicely to infiltrates. Now, what you don't know is that infiltrate and neoplasm or inflammation, that we can't tell from the ultrasound. But it does, again, raise my index of suspicion that I really need to look very closely for changes that might correlate with what we're seeing on the ultrasound. And then if you can get them, GI panels are also very helpful, cobalamin, TLI, PLI. They also can kind of cue us in on what is the likelihood that this animal has diarrhea and vomiting, weight loss from GI disease. All right. So we're talking about really two different types of biopsies. We have endoscopic biopsies and full thickness biopsies. And what I like to do at the very beginning is just tell the clinician what I'm seeing. And for endoscopic biopsies, I count the sections. And the reason I do this is so that they know what I'm looking at. Most of these endoscopic biopsies come to us on some kind of a matrix that they're secured down on or attached to. And then those go through processing. Sometimes a piece of one or more of the endoscopic biopsies will float off, and it'll float out of the plane of section. And so if I count 5 biopsies and they took 15 biopsies endoscopically, there's a disconnect there. And we may need to go back and melt that section back down and get everything back as close as we can to one plane of section. I also tell them what the quality of the sample is. How deep did it go? Did it get down to the crypts, or are we just talking about a very superficial biopsy? Do we have enough tissue? Do we have multiple crypt villus units for us to look at and evaluate? Is it oriented the right way? And is there any folding or crushing? And I've got some examples that I'll show you. Most of the time, if we think of full thickness biopsies, those are in pretty good shape and they're a little bit more straightforward. But I've got a couple examples of some problems that we occasionally see with those as well. But I put this into my report, this statement about the quality and the number, because it brings the clinician and myself closer together. They understand what I'm looking at. They understand the limitations that I have when I'm coming to a diagnosis or an interpretation. So here's an example. I'm going to show a lot of images from GI Lab, the gastrointestinal lab from Texas A&M. I want to give a special shout out to GI Lab. They're great to work with, and they've been very kind, and they let me use these pictures from cases that I've taken over the years. This is duodenum from a dog, and there's 8 sections here if you count them. I think even at this magnification, we can see that a couple of these don't look so great. There's just not much tissue there for us to evaluate. Here's what we're looking for. This is kind of the holy grail of the endoscopic biopsy. And what we have is really nice and deep sections that extend from the tip of the villus through the lamina propria all the way down to the base of the crypts. And they're oriented so that you can see the orientation of the crypts with respect to the villus, and we have multiple villi and crypts that are present for us to evaluate. These are excellent. I must say that if you look at a slide and it's got 10 endoscopic biopsies on it, oftentimes you get 4 or 5 that look like this, and the other 4 or 5 aren't so great. So that's success. That's pretty good. I think for any of us that have read endoscopic biopsies, we've all seen this. And these are just villus tips. And there's no crypts here to evaluate. We can't make any assessment about the deeper lamina propria at all. Now I look at these, and there can be information you can glean from this. You can see inflammatory cell infiltrates, you can see changes in the epithelium, and sometimes you look out and you can see lacteal changes as well. So I don't discount it, I look at it, but there are limitations for what I can tell from this biopsy. Sometimes we see this, and this is, I don't think, much better. This is a section that was really taken parallel to the wall of the stomach. So you don't have any villi. In fact, all you have is crypts. It's really hard to get your orientation here. I don't have any data to support this, but when I look at it, my eyes tell me that there's more inflammatory cells than there really should be, and that's not the case. It's just an artifact of how this was cut. And so these sections are difficult to read, and they're not, again, from this, you can't make any assessment of the villi at all. And then this is a crushed section. The architecture is there. We can see, crypts, and we can see a villus, but this is crushed. And we know this because we're seeing all this streaking and smearing, and we can't really tell what kind of cell types are there, whether they're normal cells or whether they're leukocytes. And so very little information you can get from these that are really crushed. This is a surgical biopsy. This is a very good one, and I think you can all see the mucosa with really nice villi, the submucosa, the tunica muscularis, the vasculature, and then all the way down to the serosal surface. So this is a great surgical biopsy. If we have problems, this is the one I encounter the most, and this is when we only see the tunica muscularis. Many times, this can happen for 2 reasons. One, the mucosa has been stripped off, and it's separate from the muscularis. And sometimes you can find it on the same slide. Sometimes it's just been detached and it's there and it's distant from the muscularis. You can read those. Those work pretty well. Other times, the mucosa is underneath this section, and you can't read it at all, of course. And once in a while, if you melt these down and ask the histotechnologist to reposition it perpendicular to the original orientation, you will get a piece of mucosa that you can look at. Not always, but once in a while, you're lucky and you can do that. All right. That's a little bit about assessing numbers and quality. The next thing I think it's really important to talk about is a little bit normal. I won't dwell on this. I don't want to spend a lot of time on this, but I brought a few pictures and a few rules of thumb that I operate by, and they're published in the literature and I think are very good. And I think if we kind of are all on the same page with respect to what's normal, it makes looking at the pathology, the histopathology, a little bit easier. Let's start with stomach. This is fundic stomach in a dog. And I'm going to go through some of the parameters that we look at. One is the surface epithelium, and this should be differentiated. This is foveolar epithelium. It should be a tall, columnar, and very well polarized epithelium. The proliferative compartment here is the isthmus, which is right about here. And in this case, we have proliferation of cells going up and proliferation of cells going down into the gland. It's usually very nondescript, hard to identify. The parietal and chief cells of the glands are usually oriented fairly linearly, and they're separated by 1 to 2 fibrocytes. And oftentimes those may be indistinct. You can't really see them at all. There's not many inflammatory cells there. If you do see a few lymphocytes and plasma cells, most often they're in the superficial lamina propria. I put some numbers here. I don't advocate counting cells, but if that helps, you can. These were numbers that are out there, and I got some references at the end on this. But about less than 20 lymphocytes and plasma cells per 40x field is within the realm of normal. There's intraepithelial lymphocytes within the surface, and there's a low number of those, 1 or 2 in a 40x field. And occasionally you'll see an eosinophil, not very many. I throw this picture up here. This is antral stomach. This is getting close to the pylorus. And at low magnification, as you can see on this side of the screen, it looks very cellular. And I'm always tempted to say, oh, there's a lymphocytic infiltrate into that. But if you take a minute and you go to a higher magnification, you'll see that really what you're looking at is the mesenchymal cells of the stroma of the tissue, and it's normal. And so you're dealing with antrum, you're getting close to the pylorus. It's not inflammation. So just something to look out for. This is duodenum, and we see that the villi are fairly uniform and slender. The crypts are run fairly parallel to each other. Again, this is a really nice section. There's 1 or 2 columns of lymphocytes and plasma cells that are present between the crypts. If we look in the villus lamina propria, if we were to go to a 40x field, less than 25% of that 40x field would be lymphocytes and plasma cells. Again, these are rules of thumb. I don't necessarily intend that people start counting or measuring these, but giving you an idea in your mind of what normal is. There are a few intraepithelial lymphocytes. They're in the crypts as well as the surface epithelium. 5 to 10 in a 40x field. Remember, in cats, the number doubles. There's significantly more surface intraepithelial lymphocytes in cats. I think it's important to realize there are normally eosinophils in the lamina propria, and there are not very many, 2 or 3 in a 40x field, but they are there. And I think that there is a tendency, at least I had when I first started, to start thinking I was dealing with an eosinophilic enteritis when it was really within the realm of normal for this particular animal. There aren't very many macrophages, and to be honest with you, they're very difficult to see with H&E stains. If you are seeing them, then they're probably increased. Now, in contrast, if you came in with an IBA1 or CD68, I think you'd be surprised about how many resident macrophages there actually are in the intestinal tract. Like the stomach, there's 1 or 2 fibrocytes between the crypts, again, non-distinct, and oftentimes you don't see them. The surface epithelium, and I have some pictures of this in a little bit, is tall, cuboidal. It's well polarized. The nuclei are down near the basolateral surface, and there's a brush border on the apical surface that's very prominent. The proliferative compartment here is the crypt down at the base. And the crypt really has scant luminal space. There's just not much space there normally. And it's lined by cuboidal epithelium with occasional goblet cells. Many similarities in the colon as in the lamina propria of the small intestine. Remember that the colon does not have villi. And so we see a flat surface with glands diving downward. The purist calls these glands. As I get older, I've started finding myself calling them crypts. People use them interchangeably. I'll probably try and call these glands for this talk just for the sake of not being confusing. The glands are uniform. They also are lined by goblet cells. Not very many lymphocytes and plasma cells in the lamina propria of the colon, less than 5 between each of the glands. And the surface epithelium, again, should be differentiated. But in this case, you don't see the brush border that you would see in the small intestine. Intraepithelial lymphocytes are rare. They're there. You can see a couple here in the gland epithelium, but they're not very common. You can see a few eosinophils scattered here and there, 1 or 2 in a 40x field. Oops. Let's see if I go back. And the proliferative compartment is down here at the base of the gland. All right, so that's a very superficial view of normal. And there's probably a lot more there that I'm missing, but I'm trying to think about parameters I'm going to talk about as we get into this talk and at least give you a frame of reference what normal is. Next, I want to talk about diagnosing and characterizing inflammatory changes. I like to start with this slide. Today, I'm going to talk about chronic inflammatory lesions. There's lots of acute inflammatory lesions. I'm not going to touch much on those, but there are a lot of different etiologies of chronic inflammatory diseases in the dog and the cat. And I like this slide because it kind of shows a pyramid with the most frequent, which is the food responsive enteropathies, coming up to the idiopathic enteropathies and the non-responsive enteropathies. So some of these we know what causes them. There's certain pathogen, bacteria, fungi, protozoa that we know cause chronic inflammatory disease. There's some things like food allergies or food hypersensitivities that we also know contribute to these. And for some of them, we just don't know. Idiopathic inflammatory bowel disease, for instance, we don't know what the underlying cause of that, although our knowledge base there is growing all the time. I like to use the term chronic inflammatory enteropathy to encompass all of these, and that's an established term in the literature. I use it as an umbrella term. The one thing that I avoid and I don't recommend is trying to diagnose inflammatory bowel disease on a GI biopsy. Inflammatory bowel disease is really a disease, a diagnosis of exclusion, and really where I come to on my diagnosis is chronic inflammatory enteropathy. Now that may be eosinophilic or histiocytic or lymphoplasmacytic, and I will list differentials that would include inflammatory bowel disease, but that's up to the clinician to take that further and eliminate the other possibilities, food, pathogens, and so on. This is taken from an article from Day in the Journal of Comparative Pathology. This is an older article, it's from 2008, but I think it's a very, very good article that stood the test of time. I recommend taking a look at it if you haven't. And this is the WSAVA Gastrointestinal Standardization Group's description of inflammatory changes and histologic criteria. And I like it very much, and much of this talk is really going to incorporate some of these changes, some of the things that were described in this article. There are 2 very broad categories to evaluate, and that's architectural change, and you can see the parameters beneath for architectural change, and also cellular infiltrates. Here we're talking about inflammatory cellular infiltrates, and you can see the list of the different infiltrates that are described. And then in the box at the bottom, I think it's important to realize that when we see a given GI biopsy, most of the time, we're going to see more than one of these parameters from both the architecture side and the cellular side. So let's start and spend a minute or two talking about architectural changes. And I think probably most of you know that really these are likely the most powerful indicators of inflammation that we have. They, in my opinion, are the most objective parameters that we have to evaluate inflammation. And I look at them first. Sometimes our eyes are immediately drawn to the cellular infiltrate, but bearing in mind that that may be a normal resident cellular population and not inflammation, I try to draw myself away and look instead at these architectural changes. I look at the epithelium, I look at the villi, the crypts, and so on. So I want to spend just a minute going through some of these changes individually, because I think they're very, very important. I want to talk first about epithelial change. And what we're really talking about here is loss of differentiation of epithelium. So maybe they lose their brush border. We're going to talk about attenuation of the epithelium. That's maybe going from a tall columnar epithelial cell to a kind of a short columnar or even a squamous epithelium, and then all the way to erosion. I'll draw your attention to normal stomach on this side of the screen, and you see this very well differentiated foveolar epithelium over the surface of the stomach. Compare that to this stomach, and you see that the epithelium is really poorly differentiated. You lose the foveolar differentiation. And these are very short cuboidal cells, and they even get to the point where they're almost becoming squamous. So this is really severely attenuated surface epithelium. There's a lot of other changes here too, and I'll come to those in a little bit. But this is a great indicator that there's inflammation in this section of the stomach. We don't know, for instance, if this was an area of erosion that is reepithelializing, or if this is attenuated epithelium from chronic inflammation and accelerated epithelial turnover. Here's duodenum with epithelial change. Again, draw your attention to normal, these tall columnar cells, very well polarized with the nuclei along the basolateral surface. You can really see this brush border. Remember, the brush border correspond to the glycocalyx and microvilli along the apical edge of the interocyte, and it forms this kind of a purple or eosinophilic band over the top. Compare that to this villus, and we lose the brush border completely. These cells are not really polarized. They're fairly haphazardly arranged along the basement membrane. They lost differentiation. They're kind of a short or cuboidal, and they in this case you can even see in some of these cells these guys are fairly vacuolated. That vacuolization can suggest interocyte injury as well. This is colon, and here we see some of those same changes comparing the interocytes to from the normal colon to the inflamed colon, these cuboidal, low cuboidal epithelium. But here we have an erosion where we've completely lost the epithelium over the surface of the colon. And then to take it to the most extreme, we've lost, really we have full ulceration. This is jejunum, and we have an ulceration that extends all the way down into the submucosa. And if we look at the inset here, the higher magnification, the ulcer bed is filled with degenerate neutrophils and cell debris. So kind of the end of the spectrum for epithelial injury and change in a biopsy. And of course, this is a full thickness biopsy. I think epithelial change is one of the strongest and, in my opinion, one of the easiest things to look at. Once you kind of train your mind to what normal is, it's fairly easy to see when there's a change. We're going to now switch to what I find are one of the more difficult things to look at, and that's villus blunting. And really now we're going to have to say that the quality of these biopsies is really the underlying criteria that we have for being able to identify villus blunting. It has to be a good section. It has to go from the tip of the villus all the way down to the base of the crypt, and it has to have multiple villi there. That's the only way we're going to be able to make any kind of judgment on villus blunting. If you look with me at the normal, we see that the villi are tall and they're uniform and they're slender. But even in this section, we have these two that are fairly similar, and then we have this guy that's pretty blunted. So it all is really going to depend on where that blade comes through the mucosa, and it may artifactually shear off part of a villus just because that's the way it was cut. And we can't overinterpret that as villus blunting. What I recommend you do is look at several villi and crypts in one section and then move to another section. So look at several sections. And if you're seeing short, stubby villi in multiple sections and multiple villi on the same section, that's good evidence that you're dealing with blunting of villi. Another powerful indicator is if you see fusion of villi, and that way, in that situation, you'll see a domed villus and you'll see multiple crypts associated with that. So that will fuse. That's from fusion. Another feature that you can see that not always, but many times will go with villus blunting is epithelial injury. So you can get these cuboidal or immature epithelium lining the villus, and they will also be blunted and sometimes fused. If we think back earlier to that slide I showed of just the villus tips, there's no way we could look at that and make any assessment on the appropriateness of those villi or if there's villus blunting. All right, let's talk about lacteals. I want to start with normal again first. You will see lacteals in normal sections in dogs and cats. They're usually centrally located. They're lined by endothelium. And a good way to evaluate them is to look at the width of the lacteal and compare that to the width of the villus. And a rule of thumb is the lacteal width should be less than 25% of the width of the villus. So this width should be less than 25% of the villus width. And so if you see a villus that's narrow and slender like this, that's normal, and you will see them. But if you start seeing a villus that's maybe 40 or 50 or more percent of the villus width, then you're dealing likely with dilation of the lacteals. I brought today a pretty extreme example of this in a dog. It's an endoscopic biopsy, but I think this really shows it well. And here, some of these lacteals are probably 90% of the width of the villus. Many times you will also see inflammation within the lacteal. Sometimes these rupture. You'll get macrophages and neutrophils within the lacteal space as well. This may be associated with hyperproteinemia. Remember that lymphangiectasia is not the only lesion associated with protein-losing enteropathy. The images I showed earlier of the epithelial injury, oftentimes that epithelium is leaky, especially if there's erosion, then it's going to be really leaky, and that's associated with PLE or protein-losing enteropathy. And as I'll show in a couple slides, Crypt Change or Crypt Abscesses can also be associated with protein-losing enteropathy as well. Here's something to watch out for, and I run into this from time to time, and it looks for all the world like a dilated lacteal, but this is an artifact change, and this is from the epithelium stripping off the lamina propria during processing or during collection. And the way to tell the difference is that this is usually off to the side of the villus, whereas the lacteal sits in the middle, and it's not lined by endothelium. And so that can tell you that you're dealing with an artifactual change and not really a dilation of the lacteal. So just something to look out for. All right. I alluded to crypt change. Normally, the crypt, again, should really not have much of a space at all. You can see the crypts in this section are very dilated. They're cystic almost, and they are filled with a kind of an eosinophilic debris, eosinophilic fluid, and then debris from degenerate leukocytes. And you'll hear this called crypt abscesses. I think crypt change is the preferred terminology for this. Sometimes these crypts will rupture and leak this material out into the lamina propria. This stimulates a pretty strong inflammatory response, and oftentimes you'll get macrophages in there as well as neutrophils. So that is crypt change. All right. We'll talk about fibrosis. This is not something that I commonly see, but when you do see it, can be a very important change. This is dog, and again, in the normal dog, the gastric glands line up parallel to each other with one or two layers of fibroblasts or fibrocytes between each of the glands. I think you can see in this image of this inflamed stomach that we have multiple layers of fibrocytes between these glands. The other thing that it's done is it's nested the gastric glands. You can see kind of these circular nests of remaining gastric glands. And to me, this looks all the world like an endometrial biopsy in a horse with endometritis. This is small intestine. This is cat with fibrosis. And here again, you can just see this very intense eosinophilic fibrous connective tissue that really has replaced most of the lamina propria in this cat. And then we see multiple layers of fibrocytes and fibroblasts separating the crypts. So an example of fibrosis in the small intestine. All right. Let's talk a little bit about epithelial proliferation or hyperplasia. And remember that we had different areas of the proliferative compartment in the GI tract. In the stomach, it was the isthmus of the gastric gland. In the small intestine, it was the crypt, and in the colon, it was down at the base of the gland or the base of the crypts. If we start with normal, we have foveolar epithelium that blends in with the parietal and chief cells. The proliferative compartment is right here at the junction of those two at the gastric pit, and it's usually pretty non-distinct. When you get a hyperplastic lesion, it'll look more like this picture on this side of the screen, where we have this tremendous elongation of the gastric pits. And oftentimes you'll have one of two hyperplastic cells there. The case I brought today, this is mucous cell hyperplasia. Mucous cell hyperplasia, these cells are not well differentiated. They've got basophilic cytoplasm, and you can see those here. Foveolar cell hyperplasia will look much more like the normal surface epithelium, but you can see tremendous hyperplasia in those cells as well. Another feature of this inflamed stomach is that really there's a decrease in parietal cells. You can see a few parietal cells clinging on here in the lamina propria, but the decrease in the parietal cells is a response of the gastric mucosa to injury and decreasing acid production. And so that goes hand in hand with gastric inflammation, and you can see it in cases of epithelial hyperplasia. This is the crypt with hyperplastic epithelium, and this is the normal crypt. You'll see columnar to cuboidal cells and goblet cells normally in the crypt. There's not much space there. They're polarized, meaning that the nuclei are down along the basolateral surface, along the basement membrane. This is inflamed intestine, and here you can see really a proliferation of the enterocytes, and they've lost a lot of their polarity. They're really crowded in there, one on top of another. Sometimes the luminal space is dilated as well. One thing that I don't advise is trying to count mitotic figures. There's always mitotic figures in the crypts and in the base of the glands. They're supposed to be there, and trying to count them isn't going to give you much information. But looking for these changes, the proliferation of those, the crowding, the loss of differentiation, the loss of polarization, can really give you a good indication that it's crypt hyperplasia. This is hyperplasia in the colon, and a lot of the things I just told you about in the small intestine play a role here. You have this densely crowded enterocytes along the base of the gland. When we compare it to the normal colon, one other thing jumps out at us, and that's that there's no goblet cells. And so goblet cell loss can be a finding that we see with hyperplasia of the enterocytes in the colon. Just to confuse things, sometimes the opposite can be true, and you can see almost kind of a goblet cell metaplasia. So you can see hyperplasia of the goblet cells in the colon, and that also can be an indicator of chronic inflammation. So that's a little bit confusing. Personally, I don't see goblet cell hyperplasia nearly as much as I see goblet cell loss. But if you start seeing this picture where you're not seeing very many goblet cells lining the glands, it's a pretty good indicator that you've got inflammation and hyperplasia in the glands. All right. Those are architectural changes, and there's a lot of them, a lot to keep straight. Let's talk about cellular infiltrates. And what I want to start with is my favorite, which I think is one of the easier things to evaluate, and that's intraepithelial lymphocytes. I think as far as inflammatory infiltrates go, this one's fairly objective. In the normal surface epithelium, there are a low number of scattered intraepithelial lymphocytes. You see them, oops, I'm sorry. You see them, oops, I've done something here. You see them as just these dark, really the nuclei is all you see of the lymphocytes in the intraepithelial spaces. Compare that with this inflamed duodenum, and you see lots and lots of these intraepithelial lymphocytes in the surface epithelium. You can also see them in the glands or the crypts. This is, I believe this is colon. And so you can see lots of intraepithelial lymphocytes in the epithelium of the colon. There really just shouldn't be very many there. I think if you're also thinking about this, there also is evidence here of hyperplasia of the enterocytes in the colon, and there's also a decrease in goblet cells. So again, trying to bring to mind that many of these changes go together. This is cat. And so on this side of the screen, this intestine, there's a lot of increased, there's a major increase in intraepithelial lymphocytes, especially when you compare it back to the normal feline intraepithelial lymphocytes. But we have to be a little bit careful here. And I may get time to talk about this later tonight. I don't know if we'll get here or not. But you have to differentiate this between epitheliotropic lymphoma. I think in this particular case I'm showing, this actually was a case of epitheliotropic lymphoma. And we see that a real high number, big increase of intraepithelial lymphocytes in the surface epithelium and in the crypts of a cat, maybe something that would give you pause and make you think about a neoplastic process. All right. Now let's go to what I find to be the most difficult to evaluate, and that's lymphocytes and plasma cells. And they're normally there, and trying to, the the difficulty is trying to determine when it's normal and when it's too much. And I think it's easier when inflammation is severe. When there's a severe increase or a major increase in lymphocytes and plasma cells, most of the time you can pick that up and feel confident about it. It's that hazy, murky area between normal and mild to moderate inflammation that I think for all of us is the most tricky. And remember that, and I've shown that at the bottom of the screen, there should be, 1, 2, maybe 3 layers of lymphocytes and plasma cells between the crypts. If you're on a 40x field and you're looking at the villus lamina propria, it should be less than 25% of that 40x field. If you look at this inflamed duodenum, and we scoot up to a higher magnification, you can see that the crypts are pushed apart by maybe 6 or 7 layers of lymphocytes and plasma cells. If we were to go up to the lamina propria and go down to a 40x field, maybe 50% of the field is taken up by plasma cells and lymphocytes. What I will do next, or what I hopefully have already done, is looked at the architecture and seen if are there epithelial changes, are there villus changes, are there lacteal changes, and so on. And what I'm doing is trying to build a case for inflammation and not relying on one parameter alone. And I think that's especially true for lymphocytes and plasma cells. So this is really kind of a moderate case of lymphoplasmacytic inflammation. This is a much more severe case of lymphoplasmacytic inflammation, and I think you can appreciate the large numbers of inflammatory cells here, most of which are lymphocytes and plasma cells, but also there's likely macrophages in here as well. If we zoomed up to a higher magnification, we could start to spot those. But again, look at some of these other changes. Look at these crypts. Look how hyperplastic they are, how crowded they are, so that supports our notion of inflammation. And lymphoplasmacytic enteritis on this side of the screen, we have it in the stomach, again, associated with other changes. Just as a hint, look at this epithelium up here, pretty attenuated, and also lymphoplasmacytic inflammation in the colon. One thing to be a little bit careful of when you're assessing lymphoplasmacytic inflammation in the colon and in the stomach and also in the ileum, but it can happen anywhere, is if you're dealing with gut-associated lymphoid tissue, make sure you're not over-interpreting that as a inflammatory change. And so that can be tricky on endoscopic biopsies where your orientation is not great, but usually those that cellular infiltrate is pretty well delineated, and it doesn't encompass, it can be very dense, and then that tapers off to and has a boundary that you can assess. And so it's not always easy, but many times you can differentiate between the two. I bring that up because here toward the bottom of the screen is likely gut-associated lymphoid tissue in that section of colon. Eosinophils, as I said earlier tonight, or I'm sorry, this morning, they're there, and I think a couple things. One is don't mistake them for neutrophils, and it's easy to do that. The granules, the eosinophilic granules, don't always show through, especially in dogs. If you look at the screen long enough, you'll start seeing, and it's nice because there's arrows there, but there are a few eosinophils in here, probably 5 or 6 if we counted, and that's normal. If we compare that to the other end of the spectrum on this side of the screen, where we see a really severe infiltrated eosinophils, I think all of us would be able to pick that up pretty quickly. And the tricky thing is, what do we do? How do we decide for cases where the number of eosinophils is somewhere in between these two images? What I look for are clusters of eosinophils, maybe 10 to 20 in multiple fields in the lamina propria. Then I think that clustering and that increase in numbers start to build evidence that we're dealing with a eosinophilic inflammatory change. And neutrophils just shouldn't be there. So if you're starting to see neutrophils, first thing to do is convince yourself they're not eosinophils. And once you do that, then you're dealing with inflammation. And it's that cell type, when you see it, it's inflamed. And in this case, I believe this is cat stomach. No, this is cat duodenum. And it's also associated with epithelial change and erosions. And neutrophil infiltrate and erosions go hand in hand. And so many times when not always, but when I do see neutrophils, I'll go look and scour the epithelium and see if I can see an erosion, because that may be where those neutrophils are being recruited from. Is that epithelial injury and the exposure to the luminal environment. And this is an example of macrophages. I've kind of zoomed up to a high level, I know, but macrophages, they can be tricky to differentiate from plasma cells and sometimes lymphocytes. What you're looking for is a cell with a oval nucleus and a fair amount of cytoplasm. And you also have to differentiate this from the underlying mesenchymal cells that are normally present in the intestine. But in cases, this was a cat small intestine. When you look through multiple fields, you can convince yourself that you're looking at a macrophage infiltrate. Oftentimes macrophages were there with other cells, not always, but sometimes they'll coincide with neutrophils as well, depending on the etiology. I mentioned gut-associated lymphoid tissue. One of the places that we will look at it and kind of assess how big that is to make an idea of our supporting evidence for inflammation is in the stomach. And in the stomach, this image of this is antral stomach, and there is gut-associated lymphoid tissue there, or lymphoid follicles as they're called, and they're usually pretty small. But again, as I mentioned before, they're well delineated, and you can see a demarcation with the normal lamina, with the adjacent lamina propria. This is hyperplastic lymphoid follicles in the stomach of a cat. And what you're looking for is if it's a rule of thumb is if it's greater than 10% of the area of the section, then that's pretty good evidence that it's hyperplastic. And there are some diseases that are associated with lymphoid follicles, some people call it a lymphofollicular gastritis. And I've seen this in some cases where I've suspected Helicobacter before. Other etiologies can do that as well. Sometimes if it's a surgical specimen, they'll see it grossly from the serosal surfaces, and sometimes the mucosal surfaces as white nodules. So every once in a while you'll see that. Harder to make that assessment in the small intestine, and I don't try to look at the area of that lymphoid follicle and make any kind of interpretation about hyperplasia, but I do so in the stomach. All right. That's kind of a whirlwind tour through the WSAVA parameters for evaluating and scoring inflammation. And I've alluded to this so far, that as I go along and I evaluate an endoscopic biopsies or a set of biopsies, I start building a case for whether there's evidence of inflammation. And I borrowed this from the GI lab. This is the scoring sheet that we use and we send back to clinicians. I'm not sure I advocate that you need to use a scoring sheet. At the University of Georgia, for instance, when we read endoscopic biopsies, we don't use a scoring sheet, but Texas A&M GI lab does. I do, however, keep this in my mind. And at the beginning, when I first started this, I taped this to my desk, and it did help me to go parameter by parameter to remind me to look at all of these different areas, both cellular and architectural. And in GI lab, we score them, 0 being normal on a rising scale, 1, 2, 3 being the most severe. So each of these parameters we score, and I've got some examples of that I'll show you in just a little bit. And that's what goes back to the clinician, in addition to a description and morphologic diagnosis and images. So I find it useful whether you use it or you just keep it in your mind to help you systematically evaluate the sections. Remember, sometimes the tissue is normal. When I was just out of my training program, I remember being a new faculty member at Iowa State, and I would look at these slides, 3, 4 slides with lots of endoscopic biopsies on them. And I would think, wow, they took a lot of time and effort to collect these biopsies. I really need to find the problem here. I really need to tell them that there's something wrong. And over the years, I've come to be much more comfortable saying these are normal, or at least I don't see anything that is significantly different. And although that gives many of us kind of a cramp, it's powerful and it tells the clinician a lot. I mean, we all know as veterinarians what the differential list for vomiting and diarrhea looks like. It's huge. And not all those causes are from the GI tract. And I think it's powerful information if we say in the colon, in the duodenum, and in the stomach, we don't see any evidence that would support intestinal disease. That doesn't mean it's not there, but you may also want to go and look at some of your other differentials as well. So keep that in mind as you look at these. All right, let's go through a few examples. And what I have talked a lot. So what I'm hoping we'll do is I'm going to show you 2 or 3 images from cases I've had. These were digitized cases that I read for GI Lab over the last few years. And if you just want to shoot in a couple, 1 or 2 changes that you see, changes we've talked about in the last hour, into the Q&A, just make this as interactive as we can. Me talking to you from Georgia to Australia. So let me show you the first one. I'm going to open my Q&A screen. So I'm hoping you guys will participate in this. This is a dog with chronic diarrhea and weight loss. Can you name 3 changes that are here? There's more than 3, but I'm going to show you a few images here and you name 3 changes. This is duodenum. So I'm just going to stop talking. Getting a few. Thank you so much for sending this in. Low stakes. Let's see if I can get it.
Sorry, Jess, I'm sorry to interrupt you. We have people using the Q&A and people using the chat. What do you prefer to check?
Q&A is easier for me, but either way, I can open both.
No, that's great. Yeah, we can just ask folks to enter their answers in the Q&A then.
Okay.
Yeah, you send a message for the people.
All right. Here's another image. Another image. And the last one. All right. Awesome. You guys did great. You nailed it. You got them all. So this is, I think we all saw that there, even at this magnification, you can see there's really quite a severe blunting of the villus. In fact, in some cases like this, you look at it and think, are you sure this is duodenum? Is this, it's not colon? And that can be a tough one. But there's tremendous blunting of the villi, and then this one, look at how fused those villi are. And then there's there's crypt change here. Look how dilated this crypt is, and has this fluid and some degenerate leukocytes in there as well. And then as we go to a higher magnification, I've shown you this before, you've seen it. Lots and lots of lymphocytes and plasma cells here. And the crypts are crowded and lined by hyperplastic epithelium. And then all of you caught this one. There's increased numbers of intraepithelial lymphocytes here. Lots and lots and lots of intraepithelial lymphocytes. And then last, and you all caught it, there's attenuation of the epithelium. Look at, these are just not, they're kind of haphazard along here. There's not much of a brush border. And then right there, boom, we have an erosion. And then, you know, sometimes it's a little tricky. Am I dealing with really with an erosion, or is this an artifact? A nice rule of thumb is to look for neutrophils, and here you have them right here. Neutrophils in the lamina propria, and that's a good supporting evidence that you're dealing with an erosion. So this dog has chronic inflammatory enteropathy, and it's a lymphoplasmacytic enteritis with villus fusion and blunting and erosions, and so that's what we reported out. Is it IBD? I don't know. We're going to have to decide. But this is what the score sheet looks like that I would send out anyway, and gives them an idea. I put in this section, I also looked at stomach and colon, and I put my scores for that as well, just so you can see it. All right. That was fun. Let's do another one. This is duodenum from a dog. Name 2 changes. This one's harder. I go to a little higher mag. Remember, this is you guys are doing great. All right. Again, you nailed it. Let's see, let me go back up. This is lymphoplasmic enteritis, but this is more mild. For those of you that said Villus Blunting, I'm with you there. You can really see that. Again, you can, as you follow along the surface, most of them are blunted. And then what I would do is go look at another section and then another section to build my confidence that we're really dealing with Villus Blunting. Remember, I said that's a hard parameter to look at, but if you can convince yourself, it's pretty powerful. This, I think, right here may be evidence of villus fusion. We've got one villus here and multiple crypts coming off of it. All right, so good. And then in this image, you can see multiple, you know, probably 6 or 7 layers of plasma cells and a few lymphocytes pushing the crypts apart from each other. And then an increase in IELs, but a lot more subtle than the last time. And I like this one because it just shows you that we're just starting to move out of normal and into kind of mild to moderate lymphoplasmacytic change. And this also, we can confirm our suspicion of inflammation by seeing some of the other changes there, such as the villus blunting and fusion and the increased IELs. It's very good. You can see the difference between when you have a really severe lymphoplasmacytic inflammation that's fairly straightforward, and you can see it right away, to mild to moderate inflammation. which is a little trickier. This is how I scored this one. Quite a bit different than the way I did for the first sample, first case we looked at. All right, here's colon from a dog. Name 3 changes. I won't tell you the breed. I'm going to give you a little higher mag. You guys are right on top of it. You have it. Somebody want to throw out a differential? All right. This is granulomatous, and ulcerative colitis is my morphologic. There is really severe erosion and ulceration here. Just you can see these interocytes just really barely hanging on, and then completely devoid here. And the lamina propria is filled with lots and lots of macrophages. Goblet cells are decreased as well. And again, you can see this, the epithelium is really just barely hanging on, and where it is very attenuated. So this actually was a boxer dog, and this was histiocytic and ulcerative colitis syndrome, which we now think is related to an attaching an invasive E. coli. I haven't thought about that in a few weeks, but a pathogen in E. coli that's associated with in boxer dogs, and I think French bulldogs actually now as well. We're seeing this, so we have more of an etiology for this chronic inflammatory condition. Here's my score sheet for that. All right, one more. This is stomach. Name 2 changes, or 3. There's actually more than 3, but. And this is fundic stomach. I'll go up a little bit in mag. Good. Glad somebody saw those cells. Give it another 30 seconds or so. I don't want to cut anyone off. All right. Excellent. I truly appreciate you all participating. This was dog. This was a severe gastritis. It doesn't show in this, but what I wanted you to see here was the really attenuated surface epithelium. Look, it's a cuboidal to flat. not well differentiated. That should be really differentiated to foveolar epithelium. The other thing there is there's really not many parietal cells at all. It's kind of a wonky cut. I apologize a little bit for that, but there's loss of parietal cells, and many of you hit on that. And there's mucous neck cell hyperplasia. So these are all mucous neck cells, and they really expanded the gastric pit. So, epithelial attenuation, mucous neck cell hyperplasia. And then if we drop a little farther in the lamina propria and bump up our mag a bit, lots and lots of neutrophils in here as well. And you can also get an idea from this that there's a loss of parietal cells. And this is how I scored this particular case. I don't know the cause, the underlying cause for this. There was inflammation in other parts of the digestive tract as well. All right. Any questions about that? Those are good cases. All right. I want to share with you some philosophical thoughts right now. One is that poor quality biopsies often don't help us very much. We take a look, we see how far we can get, but really we're dependent on getting good quality biopsies. I've said it before, and I think it's important. Sometimes the biopsies are normal, and that's okay. Architectural changes are the most powerful and objective changes to look at. Try and look at them first. Inflammatory changes, especially lymphocytes and plasma cells, can be difficult to define, especially when they're mild. And I'm going to go for another 15 minutes. We can talk a little bit about the low-grade lymphomas and how they're a little bit more difficult to differentiate from inflammation. Got some questions here. I'm hoping I can come back to these in a few minutes when we talk a little bit about neoplastic changes. All right. Well, I do have a few slides. I want to talk a little bit about infectious agents. I brought these along just because they're kind of neat. They're difficult. Usually we don't see, it can be difficult to see infectious agents on endoscopic biopsies. And sometimes on full thickness as well. We can use special staining. GMS or PAS for fungi is good. Gram stains are sometimes if you're lucky. And if these are negative, it doesn't mean they're not there. They just aren't there at a density that your stains are going to pick them up. PCR and fish are something that are pretty helpful, as well as culture when needed. This is the only time I've seen this. This was a dog with, we used to call this Isospora, which is now Cystoisospora canis. And this was a puppy with chronic diarrhea and got an endoscopic biopsy. I think normally they probably wouldn't do an endoscopic biopsy, they'd worm it, but it probably been through several rounds of worming. And but you can see the different life stages of the protozoa in the lamina propria, and I bring that along just because I thought it was kind of neat. Does anybody see anything here in this cat next to the green arrows? I've seen this once. Yeah, this is Cryptosporidium. Notice the tremendous increase in the intraepithelial lymphocytes. I worried that this was lymphoma, and I still am not convinced it's not, but there was certainly a lot of Cryptosporidium in this case. And look at how densely the lymphocytes and plasma cells are here. Look at here, these are all plasma cells in the lamina propria. So only time I've ever seen it, but it sure was interesting. This is a cat stomach. Anybody have any guesses as to what this is? What I thought this was anyway? Chronic vomiting, diarrhea, and weight loss. Yeah. I thought this was a good, we had evidence here of Helicobacter. You see these spiral bacteria in the lumen. Remember that you will see those in dogs and cats out here in the luminal surface or the superficial gastric pit, but when they start getting deep and down in the deeper parts of the gastric pit and down in further into the gland, I think that's significant. And then for me, like you see here in this image, a pretty intense lymphoplasmacytic infiltrate around the glands. That also is a pretty good indication that you're dealing with, at least it incriminates Helicobacter in this cause. All right. There we go. This is a dog, could be the same as the one we saw last time. This is an extreme close-up of the colon. Anybody see an etiologic agent here? While you're looking, I'll answer one question about how would you definitively confirm the presence or absence of lymphoma in that crypto case. I probably would send it in for PARR. Because you're going to do if I do CD3, it's going to light up strongly in the epithelium. I think you'd have to use PARR or treat for crypto and see if it gets better. Anybody see any agents? Yeah. This is histoplasma. You can see these. This of the organisms that you might see on endoscopic or full thickness biopsies, histo is one of them. And this was dog. And so a number of these small punctate organisms in the macrophages. Looks all the world like that histiocytic and ulcerative colitis I showed a few slides ago. There they are right there. And the PAS is pretty dramatic. I always like to show that, just loaded with yeast. This is kind of a gee whiz. I brought this along. This was a case I had. This was ileum, and it had this ulceration and almost a fibrinonecrotic membrane. This was a dog with acute vomiting. So this is really one of the few acute things I'll bring along. But I've not seen this very often. This dog had a lot of bacteria lining the villi. And I don't know what this means. I don't know if it was overgrowth from ulceration. I don't know if it was primary. A lot of them were gram positive. I just show that gram stains here did work to show it. Bacteria were here. I recommended that they do FISH or PCR to try and get a better idea of what was going on. I only bring it to show you that occasionally you'll see bacteria associated with these. All right, I've got a few minutes left. Let's talk a little bit about neoplasm, especially in cats. I think full thickness biopsies are my favorite to try and evaluate neoplasms. Often that's not the case, but if you can look for evidence of invasion into the muscularis, that's really, really powerful. We don't get that with endoscopic biopsies. I've talked a little about the challenge between discriminating lymphoma from lymphocytic inflammation. That's very true of cats. It's also true in dogs. And many times both conditions, you both have a neoplasm and inflammation there at the same time. And many times I've seen cases where we get a biopsy, but the biopsies are peripheral to the true underlying lesion, especially if you have a neoplasm it's in the submucosa or the wall of the intestine and you take endoscopic biopsies, they're just not going to show it. Alimentary lymphoma is very common. It's one of the more common causes it's one of the more common lymphomas in cats. It can be in the mucosa or it can be transmural. We see B and T cells, and there's a term here many of you may have heard before, this enteropathy associated T cell lymphoma. It comes to us from the human literature, but I see it entrenched in the veterinary literature, and I've used it. The EATL is the acronym, and EATL type 1 are the large lymphocytes, high mitotic. These are kind of the blastic lymphomas. Oftentimes these these can be in dog B or T. We see them occasionally in cats too. EATL type 2, these are the small to intermediate sized lymphocytes. These don't have very many mitoses. This correlates to the small cell lymphoma that you probably already have heard of or seen when you're on biopsy. We get variations on this. We get large granular lymphocytic lymphomas, and we also see a particular type of T-cell lymphoma with lots and lots of eosinophils, and it makes you almost think it's a mast cell tumor when you're looking at it. What I want to focus on is this low-grade or edal type 2 lymphoma in cats. We have some tools in our toolkit that can help with this. I mentioned in one of your questions about differentiating an underlying etiology, and CD20 and Cd3 immunohistochemistry are probably what are used the most. And I use these all the time to help me get a better handle on the lymphocytes that are there. PAR is really helpful as well. I don't usually jump to that first. Sometimes I do. I don't know much about Ki67 IHC, but there are some reports in the literature of that being beneficial, especially for low-grade lymphomas. This low-grade or edal type 2 lymphoma in cats is best described in cats. It will happen in dogs, not very often, but once in a while. It is very difficult to differentiate from lymphocytic inflammation, and more often than not, both inflammation and lymphocytic neoplasm are there at the same time. And there's a lot of hypotheses out here, and I think that there's some evidence that this actually represents a transition from lymphocytic inflammation to lymphoma. I use IHC a lot for this, and sometimes I bring in PARR. Many of us have seen this, and this is really the full-blown low-grade or small cell lymphoma, this edal type 2. This is a cat. The whole lamina propria is packed with these small to intermediate sized lymphocytes. They have hyperchromatic nuclei. There aren't very many, if any, mitotic figures, and there's also often an increase in intraepithelial lymphocytes. And so this one is fairly straightforward to diagnose as low-grade or small cell lymphoma. This is a higher magnification. You can see the lamina propria here is just packed with these small lymphocytes. And when we look at the epithelium over the surface, it's got lots and lots of intraepithelial lymphocytes. Another thing that's very helpful here is seeing clusters like this cluster right here of intraepithelial lymphocytes. And so all of those things are big tip-offs that you're dealing with a low-grade or small cell lymphoma. This is a case of a small cell lymphoma. This one actually went all the way, it was transmural, went all the way through the wall, goes, you can see it penetrating. This is the mucosa. This is a little bit of a wonky section. This was a surgical section, but this is the mucosal surface submucosa, and this is muscularis, and this was actually serosa. These were small cells. This was a low grade, and it was actually a dog. It's an unusual case, but it was transmural in this dog. So here's the million-dollar question: how do we tell in cases that aren't so clear-cut? You know, I just showed you a slide where it was pretty easy to make that differentiation. Small lymphocytes were just packing the entire lamina propria in the epithelium. What about when that doesn't occur? Like this case. This would be a cat with chronic vomiting and diarrhea and weight loss. I do like to understand if there's weight loss or not in these cases. And you look at this and you scan around and you see that. And what this is one piece of evidence. It's not all the evidence, but it's one piece of evidence that you may be dealing with a low-grade lymphoma, and that's small lymphocyte clusters at the Villus crypt junction, which is just about where we are in this slide. This is an article by Pierre Moore's group. Again, this is back in 2012, but it's still a very good article. If you haven't looked at it, I would recommend you take a look at it. And what they describe is patches and bands of these neoplastic small lymphocytes in the lamina propria as being kind of an early form of this, and eventually spreading or progressing to where you have very dense infiltrates and ultimately involving the entire lamina propria. But I think you can see these here, these patches and bands of small lymphocytes that are associated with low-grade lymphoma. And this is what we have here. And when I report these out, I report it as lamina propria clusters of small lymphocytes. And I say that this is something that can be seen with low-grade lymphoma, and I recommend IHC. Let's do a CD3 and a CD20 and get a handle on this, what those are. If those are all CD3 cells, then that raises my suspicion that it's lymphoma. And the intraepithelial changes are important as well, and we can see a couple of patterns. One are these small clusters of intraepithelial lymphocytes. Usually they describe it as being more than 5, and this came from Mehdi Kupel's report back in 2011 on developing some algorithms for discriminating low-grade lymphoma. And then the other pattern is a plaque, and this is a plaque here at the bottom, and that's just a very dense kind of infiltrate of small lymphocytes into the epithelium over a couple of fields of enterocytes. And both of those changes are associated with low-grade lymphoma. Here's an example of that. Here are these intraepithelial clusters in the blue circles associated with low-grade lymphoma. So this is a good example of a Cd3 immunohistochemistry on these cases. And I think that when you look at this, you can really appreciate this is the epithelium. And again, this is only villus tips, I realize, but you can really see the very dense infiltrate of Cd3 cells, positive cells, and intraepithelial lymphocytes. And I use the stain really, there's not going to be B cells in there. They're going to be Cd3, but it can really tell you how many there are in there. And then this image really shows the villus lamina propria with lots and lots of these Cd3 cells. And so this is a finding that's consistent with low-grade lymphoma. But when you do your B cell stain, you will more often than not find a number of B cells in the deeper lamina propria. And you know, that may be a reflection of prior or concurrent inflammation that's there as well. So these are not always straightforward, and usually it's a mixed pattern. But one thing I'll look for is the villus lamina propria having a dominance of CD3 positive lymphocytes, and then that, and if you're lucky, you'll see the intraepithelial change as well. All right. And then lastly, I'll finish out here. Well, I've got one more slide after this I'll show you, but this is PARR. I suspect that all of you know more about PARR than I do. This came out, you know, I was fairly old by then, and now I'm really old. And so I'm not really up on the technology, but what we're looking at is a clonal population of the T cell receptor. And this would be kind of the readout you would get for inflammation, which is a broad curve showing a polyclonal population of lymphocytes or polyclonal T cell receptors, and that's typical of inflammation. Whereas on this side of the image, you have a clonal population, and that clonal population is much more indicative of a neoplasm with one T cell receptor. It's not always that clean. And sometimes there's a discrepancy. I've had cases I can tell you where I was sure by immunohistochemistry and by the H&E that it was low-grade lymphoma, and we do the PARR and it comes back as polyclonal, and vice versa, where what I thought was really looked like inflammation. There's lots and lots of plasma cells in there. I didn't see the intraepithelial change I mentioned, and we do the PARR and it comes back as clonal. And so just be advised that sometimes everything doesn't line up just as nicely as you want it to. And that kind of brings me to my last slide, and this comes from Mehdi Kupel's article in 2011. I think, again, this is a nice article, but it's complex and I think it's accurate. You know, I show this to our residents, and just that you start with histo and you feel like it's inflammation, and they treat it. And more often than not, it either responds and they continue treating, or it doesn't respond and they may come back and say, okay, let's go back and do the immunohistochemistry. If we go earlier back to the histopath and we think it's a lymphoma, we do the immunohistochemistry for B and T, and that may tell us, yeah, you have an indication this could be lymphoma, treat accordingly, or maybe it's a mixed population and you go back to inflammation. So it's kind of a circle, that a complex convoluted path that really is based on histopath, immunohistochemistry, PARR, and response to therapy. You know, some of the cases are difficult to tease out what it is, and some of them are very straightforward. I think with that, it's a little after 8:30, and I promised I would stop after about an hour and a half, and that's where we are. And so that's where I'll end, and I'll take some questions. And the first one was the colon case scored, the loss of goblet cells is listed separately, as it is not an indication of, yeah, they're in, as not an indicator of crypt attenuation. In that scoring system, it is listed differently. I think it's part of the same process. What they're really talking about in that with crypt attenuation, they're talking about crypt change. They're talking about dilation of the crypt and infiltration of neutrophils and material into the crypt, and that will happen in the colon as well. And so that's what that crypt change is about. The goblet cell loss is in my interpretation part of hyperplasia and loss of differentiation. I have another question about what do I consider normal crypt to villus ratio. That is really a hard question, and it's hard because it varies based on whether you're talking about a dog and a cat, and of course it also varies based on whether you're talking what part of the intestinal tract you're talking about. Generally speaking, the longest villi in my experiences are in the distal duodenum and in the jejunum, and the short stubbier ones are in the ileum, but I don't exactly have a great measurement on that. I don't try and make that ratio. Some pathologists do, and I think there probably is merit in doing that. I've been part of a few different studies where we have measured crypt villus ratios in different settings, inflammation and in homeostasis and under different nutritional planes. And I find with morphometry that is a really hard question to answer. So where I've come to in my path, Kathy, is that I don't try and do it for individual cases. I'd rather look at trying to assess villus blunting by looking at looking across different sections and looking to see if I can convince myself that there is a stubbiness or a blunting and fusion of those villi. I hope that answers your question. It's a difficult question to answer. I've got a question about eosinophil distribution, and this is from David, and I think what you might be driving at is that in some cases in the small intestine, especially the lower small intestine, distal jejunum and ileum, you'll see a band of eosinophils just deep to the crypts. And I see that a lot, and I have struggled with that interpretation over my career. And after consulting with other pathologists, if that's 1, 2, or 3 cell layers deep below the crypt of eosinophils, I tend to ignore it. But if it's getting more than that, if it's 5, 10 layers of eosinophils deep to the crypt, and then I start looking in the lamina propria, and I see that I mentioned before those clusters of eosinophils, 10, 20 in the lamina propria as well, then I start thinking that this is likely eosinophilic inflammation. I think I answered Isabel's question about crypto. I've got a question. I've seen a remarkable increase in intraepithelial lymphocytes with intestinal cryptosporidiosis in a leopard gecko before. I had a mast cell infiltrate. So that's really helpful. I suspect too in that case that it was related to the crypto, especially since there were so many plasma cells there. It looked very inflamed to me. Three-year-old cat, poorly preserved, jejunum perforation, monomorphic lymphocyte population, but only submucosa muscularis. Possible lymphoma without mucosal lesion. The answer, I would say, is yes. And I guess I would wonder what kind of biopsy was it. Of course, it's full thickness, but how much did you have? And it may be that in a region adjacent to where your biopsy came from, that it was more of a full thickness and it was in the mucosa, and then was spreading out in the submucosa and in the muscularis into adjacent areas of the intestine, and that would be maybe how I would interpret that. The other possibility is it's coming down from gut-associated lymphoid tissue, and that GALT is the major source of that neoplasm, and that's spreading downward into the lamina, into the submucosa, into the muscularis. That's a reasonable hypothesis as well. A question: when I see mucosa that's lifted off the lamina propria, I think this is relation to the slides I showed where it had torn off and it looked for all the world like a dilated lacteal. Does that suggest to you that there is intestinal injury because that mucosa doesn't normally lift off? And if I do suspect that, and that's a really good question, and that's definitely a possibility, I would look for evidence that that epithelium is injured. And so the changes, I would go and look for the changes that we talked about earlier. Did it lose its brush border? Does it have vacuolation? That vacuolation of the cytoplasm can be a very acute change. Is it poorly differentiated? Does it have signs of injury? And if it does, and it's lifted off, then I would think those two are related. If it's really well differentiated and it's got a brush border and it's polarized and it looks like its neighbors that aren't lifted off, I guess I would need a little more evidence to make me think so. Once in a while, though, I see it with fluid. You'll have fluid in that pocket, and at least an eosinophilic fluid, and then you have to scratch your head and think, could this really be an acute epithelial injury? So hard question to answer, and a very good one. Some cats have lots of goblet leukocytes. Yeah, I've been there with you, and I scratch my head and I don't know what to do with it. I list it, and I've seen them in the lamina propria, and I've seen them in the epithelium. I list it and I make an interpretation, that I don't think this may be related to an inflammatory change. I tell them I don't interpret this to be part of a neoplasm, but it's very difficult, and it's I think probably that it would be nice if we could get some answers on what that actually means. And then Julie asked a really good question. Do you place any significance on the presence of plasma cells extending toward the tips of the villi? I know some pathologists who say plasma cells within the outer 1/3 of the villus are abnormal. I've read that as well. I don't know that I put a lot of emphasis on where they are in the villus. That may very likely be true, but in my experience, I've seen cases that I thought were normal, and I'll see a few scattered plasma cells all the way to the tips of the villi. Now, that begs the question: am I interpreting it correctly? And is there inflammation that's mild and I'm missing? But I don't try to decide if it's in the outer third. And maybe that's something I'll keep looking at, but it's a very good question. I don't want to discount their observations or their thoughts on that. It may be true, but I typically don't do that. Is it common that there might be infiltration of eosinophils in the case of fungal granulomatous gastritis, enteritis, or colitis? Well, I'll tell you what. I think the answer is yes. Where I haven't lived in Georgia very long. I've been here 2 years, and we have something that we didn't have in Iowa, which is swamp fever, which is Pythium. And it's pretty common here, and it causes and it's kind of a fungus, it sits there in a funny category, but it's very eosinophilic rich with macrophages. And when we start seeing that in the GI tract, we start thinking about pythiosis. And I think in other fungal diseases as well. So I wouldn't rule it out. And if I see that inflammation, I recommend PAS or GMS on those. So I think the answer to your question is is yes. And David asks, is there does feline lamina propria fibrosis have a correlation with disease? And David, I think you're talking about, which I danced around and haven't talked about, but it's that funny eosinophilic change that's kind of this linear pattern in the mucosa of some cats. And the answer to your question is I have absolutely no idea. And I don't think you're talking about the picture I showed, which is pretty overt fibrosis. If you did a trichrome, it would be loaded and you've got loss of the crypts because there's so much fibrosis. That's not what I'm talking about here. I'm talking about these cats that have this kind of funny band, almost linear through the lamina propria. And it looks like it's kind of a sclerotic change. And I've talked to other pathologists. After a couple of these meetings, I've had some calls and we've talked it over. And to the best of my knowledge, in that case, in that entity, whatever that is, it's not associated with disease. I describe it, I say it's there, and I say that we don't know what the significance is, but it's often not correlated with disease. And that's about the best we can do with that. At least I can do with that. Is lymphoid effacement enough evidence to call lymphoma in cats? I've seen cases or two of lymphoid tissue with effacement into the lamina propria. If I understand your question right, you're not talking about gut-associated lymphoid tissue. That you're talking about lamina propria, where you've lost the structure because there's so many lymphocytes there, and for what we call large cell lymphoma, that, or depending on how you want to call it, the EATL type 1, lymphoblastic lymphoma, I think the answer is yes. If you see that obliteration of the lamina propria architecture by a monomorphic population of lymphocytes, you really have powerful evidence to suggest you have lymphoma. It would be hard pressed to call that inflammation, both in cats and in dogs. I think that the same holds true in those cats that I showed you, where you had the same picture of that just incredibly dense infiltration of small lymphocytes throughout the entire lamina propria and into the epithelium. I think that's also true. So I still recommend IHC on those, one, to confirm if it is that blastic morphology that we just find out if it's T or B. But I think usually that's the case. Is there any connection between increased number of Helicobacter and gastric lymphofollicular hyperplasia? To the best of my knowledge, and something I really have to fall on the sword on for all of you on this call tonight. Remember that I 2 years ago stepped away from being a full-time pathologist, and mostly I'm an administrator now. So I'm a little bit behind in my literature, but in cats, I think that there is evidence, yes, that Helicobacter associated with that deep penetration into the glands and lymphocytic infiltrates, and then lymphofollicular hyperplasia, that can be a picture associated with gastritis associated with Helicobacter. In dogs, it's just, I don't know that the cause and effect has really been made. And there's lots of dogs walking around with Helicobacter that are feeling fine and don't have gastritis, and vice versa. Lots of dogs with chronic lymphocytic gastritis that don't have Helicobacter. So we don't, I don't know that we absolutely know the association there, but in dogs, I think it's better in cats. And then I've got a 17-year-old cat, chronic constipation, vomiting, biopsy shows Cd3 lymphocyte infiltrates, mucosa, submucosa, and also surrounding plexus ganglion cells, but not prominent in muscle layer. It's type of small cell lymphoma with neurotropism, never seen it before. I have not seen that before either. And I guess my question is, probably what I would recommend in that case is PARR. It may also, I guess you'd have to think, is it some kind of a neuritis in the intestinal wall? That's a confusing one. I've not seen that before, but I think PARR might be able to help you tease out whether that's an inflammatory population or a neoplastic population. How common is gastrointestinal stromal tumor in dogs and cats? I think the answer is it's really common. I was on biopsy duty last week and we had two, both in a dog. I don't know the incidence of those in cats, but I believe that it happens there as well. I think that we know more about GIST now than we did before, and I think what we used to diagnose is smooth muscle cell tumors in the wall of the intestinal tract. Many of those probably were GISTs, and this one that we did a smooth muscle actin and now we have c-KIT, and we know c-KIT. And I think there's another one too. Is it called DOG1? I think I learned about that in the last seminar I was in. DOG1 and c-KIT are pretty good at teasing out if it's a GIST, and so we have these really good markers, and I think we're seeing more and more gastrointestinal stromal tumor. Hard to differentiate those on H&E. Any other questions? You guys have been an outstanding audience this morning. I've really enjoyed having a chance to come and visit with you. You know, if you, I hope that this has helped you and will provide you with a little bit of information that you find useful as you navigate your way through GI biopsies. So if there's no questions, I will stop and turn it back over to Javier.
Doctor, thank you so much for your presentation. Personally, I really like it because I like when the professor, they use a normal histological slides together with the lesion. That is so helpful for us. And the exercise you make with the participant was really good. Thank you so much, doctor.